A warm welcome to all clinical pharmacists, pharmacy students, and participants. On behalf of the Federation of Clinical Pharmacists of India, it's my pleasure to officially launch the Pediatrics and Neonatology Forum. This forum aims to strengthen pediatric and neonatal clinical pharmacy practice through structured, basic, and advanced modules delivered by experienced clinicians and clinical pharmacists. Through this platform, we will explore pediatric pharmacy concepts, dosing principles, and best practices in pediatric medication use. So let's begin this journey with our very first session titled Caring for the Tiniest, an Introduction to Pediatrics and Neonatology. To deliver the session, may I invite our esteemed faculty, Dr. Juliet Johns, Assistant Professor in the Department of Neonatology at Believers Church Medical College Hospital. She has completed her MBBS from Government Medical College Ernakulam and her MD in Pediatrics from AIIMS Raipur. She is currently serving in the Neonatology Department in BCMCH. We are confident that her session will set a strong foundation for this forum. On behalf of the FCPI warmly welcome you, ma'am. Over to you.
Welcome everybody to today's introductory section. I am Dr. Juliet Johns. So we are taking a basic module on the introduction to pediatrics and neonatology for clinical pharmacists. Onto the topic. Today's learning objectives are: we would like to define the key age groups in pediatrics and neonatology. We'll understand the global neonatal and pediatric epidemiology, which is relevant to pharmacotherapy. Describe in detail the pharmacokinetic and pharmacodynamic differences in neonates and children versus adults, and identify the challenges in drug dosage and usage. So the definition. So neonate is a child who has just been born. Preterm is a baby who has been born at less than 37 completed weeks of gestation. Term baby from 37 to 42 weeks of gestation. And postterm baby who has been born at more than 42 weeks of gestation. So neonatal period is till the first 28 days of life. So we need to understand the difference between gestational age and postnatal age. Gestational age is the complete weeks of gestation at which a baby has been born. Postnatal age is the chronological age of the child. The term corrected gestational age is used for preterm babies. So a baby who has been born preterm, we add the chronological age to the gestational age to get the corrected gestational age. For example, a baby born at 28 weeks of gestation, if he is currently 2 weeks old now, corrected gestational age would be 30 weeks. Other than that, you can also classify newborns according to their birth weight as extremely low birth weight, that is less than 1 kilograms, very low birth weight less than 1.5 kg, and low birth weight less than 2.5 kg. There is also a classification depending on weight percentiles for gestational age. Appropriate for gestational age falls between 10th and 90th centiles of weight for gestational age. SGA is small for gestational age, less than 10th centile of the weight which is required for that age. LGA when the weight is more than the 90th centile required for the gestational age. Then after 28 days, so from 1 month to 1 year of age, children are known as infants. From 1 to 3 years, they are toddlers. 3 to 12 years, child, and adolescence begins from 12 to goes up to 18 years. So we all know the major causes of neonatal and infant mortality are prematurity, infections, birth asphyxia. When it comes to infant mortality rate, we have other infections like lower respiratory infections and diarrheal diseases. In under 5 mortality, other than that, we also have malaria. And there are regional disparities between the high-income countries and the low-middle-income countries. We have more of the infectious causes. This shows the infant mortality rate in 2023. So the areas shaded in red have mortality rate of 4%. In the distribution over the years, the neonatal mortality, infant mortality has dropped. Child mortality rate, as you can see, again, the red shaded areas have a higher mortality rate. And the areas which are in green have reached the Sustainable Development Target goal of 2.5 deaths per 100 live births. So that is why we have a requirement to understand how pediatric dosing works. So the common childhood illnesses which need pharmacotherapy. So respiratory infections, diarrheal diseases, vaccine-preventable diseases, malnutrition, and congenital anomalies. Some common classes of drugs are antibiotics, antihistamines, analgesics. There is also a lot of off-label and unlicensed drug use in neonatal and pediatric settings. So we come to the factors affecting pediatric drug therapy. So the pharmacokinetics and pharmacodynamics are different for children with respect to adults. The formulation of drug required to be different. Also, the psychosocial aspects of drug prescription, like the counseling, is a bit different. This is an example of a drug dosing which is based on the weight and the gestational age and post-indication. This is gentamicin, as you can see. So dose and the interval differs based on the postmenstrual age and the postnatal age. So now we will look at the pharmacokinetic differences. So in pediatric patients, the pharmacokinetics and pharmacodynamics of a given drug would be different. It is because of some extrinsic factors like any acquired diet, the diseases, any xenobiotic exposure, and because of many intrinsic factors like gender, phenotype, or ethnicity during the first 2 decades of life. So neonates, especially preterm infants, they would have immature organ systems. There would be a very high variability in the absorption of drug in its distribution, metabolism, and excretion. And this affects the dosing, the onset of action, duration of action, safety, and efficacy of drugs. Let's discuss this in detail. The pharmacokinetic differences in absorption. So as we all know, children are not small adults and neonates are not small children. There are a lot of differences in the maturation of organ systems, which would affect how the drug is being handled. In the absorption, the gastric pH in neonates and infants, it is less acidic at birth. It matures over days or weeks. So the acid labile or basic drugs, the absorption would be altered. Penicillin, erythromycin, acid labile drugs will have more absorption in neonates. Weak acids like aspirin or phenobarbital have less absorption. The gastric emptying time and intestinal motility, it would be slower, it would be irregular. So the Tmax is delayed, absorption would be variable. An example is paracetamol, the oral absorption is delayed and so there is a slower onset of action. And digoxin has a very variable absorption. The skin permeability. Neonates and infants have thinner skin, it is more hydrated, lesser number of layers with a higher surface area to body weight ratio. So the percutaneous absorption of drugs would be increased. It would be more than what we usually expect. An example is systemic toxicity in neonates with hydrocortisone. Intramuscular absorption is also different because the muscle mass is poor, the perfusion would be lesser, so it is unreliable. Many drugs, instead of IM, like gentamicin or ampicillin, instead of IM, it is preferred to always give it IV. Coming to the differences in distribution. So infants have a higher total body water and a lower fat content. So because they have a higher total body water, the water-soluble drugs would have a larger volume of distribution. So hydrophilic drugs like aminoglycosides, they would need a higher dose per kg to achieve the therapeutic level. And because they have a lower fat content, the lipid-soluble drugs would have a lower volume of distribution. The plasma concentration might be increased, and also because there's an immature blood-brain barrier, there would be more CNS penetration. Examples are drugs like diazepam and barbiturates. The plasma protein levels are also lower and the quality is also different. The binding might be lesser, especially with fetal albumin. Because there is lesser protein binding of drugs, there can be a higher quantity of free or active drug. There is a risk of toxicity. Example is phenytoin and cotrimoxazole. They can displace bilirubin from its binding sites on plasma proteins on albumin. So there would be an increased risk of bilirubin-induced neurological dysfunction. And there is a more permeable blood-brain barrier. So many drugs like morphine and bilirubin, they can cross more easily into the central nervous system. So the CNS toxicity of various drugs would be higher. Now coming to the differences in metabolism. The drugs they may be metabolized at the liver. So the liver enzymes would be immature in neonates. The maturation would take several weeks to months or even years. And the enzyme expression, the timing would also be different. Some of the cytochromes, they can develop earlier, others might require more time to reach their adult level of activity. This impacts the half-life of drugs which need hepatic metabolism. So they might need longer intervals or lower doses. Example is we have linezolid, which has around 6 hours of half-life in adults and is given BD. However, in children less than 12 years, the half-life is much smaller, around 2 to 3 hours. So it is given 8th hourly in children because the clearance is much faster. But in neonates, less than 7 days, say, the half-life is much larger, 10 to 12 hours. So again, they are given a dosing which is BD. That is, they need a longer interval because the clearance is slower. Another example is levofloxacin. In adults, the clearance is around 6 to 8 hours. It is given once daily. But in children, the half-life is much smaller. So in children less than 5 years of age, we give it BD. They need divided dosing because they have a shorter T-half. All kids can take it once daily. We come to the various maturation of the various organ systems. A shows the percentage of adult activity of the various enzymes, the cytochromes. So at birth, the activity is very less. It increases over days and months. At 1 to 10 years of age, some of them might even have a higher activity than the adult level. So the metabolism might even be higher. Coming to the distribution, as you can see in the graph, preterm neonates have around 80% total body water. Term neonates have around 75%, and as age advances, it dips down to the adult level of 60%. And the total body fat in neonates is also very less. It would increase with age to reach the adult levels. Coming to the gastrointestinal function, as the graph shows, the acid secretion in the stomach is lesser at birth. It increases over the next few months. The bile acid secretion is also lesser. It changes in the GI function. The absorption of various drugs vary with age. Acquisition of renal function is shown here. Neonates have a very low renal function. Okay, and that increases over the next few months to adult levels by 6 months to 1 to 2 years. The tubular secretion and absorption are also much lesser at birth, and they also increase slowly. The development of the integumentary system, the skin, the thickness is lesser in neonatal age group, especially in preterm. The number of layers are less, the perfusion is higher, the hydration is higher, and the surface area to body weight ratio is higher. This decreases as the child matures and ages to term and to older age groups. So the differences in excretion based on the renal maturity factor. Neonates have a very low GFR, so the clearance is reduced. So the renally eliminated drugs would have a prolonged half-life, like vancomycin, aminoglycosides, and digoxin. They would accumulate if we do not adjust their dosing. The tubular secretion is also limited. So many drugs like penicillins and cephalosporins and digoxin, the elimination would be slower when they actually need to be secreted via the tubules. Tubular reabsorption is also reduced. So there are altered pharmacokinetics for diuretics like furosemide and for theophylline because the handling of electrolytes and weak acids or bases is altered. Overall impact is that the drug half-life is prolonged. So we either need lower doses or longer intervals. An example is that gentamicin dosing in neonates, it can be Q24 hourly to 36 hourly versus the 8 hourly dosing in adults. So pharmacodynamically also there are a lot of differences. There are differences in the receptor sensitivity, in the receptor density and number. The maturation of organ systems also leads to altered responses and side effect profiles. And drugs with narrow therapeutic windows, there are adverse effects which have not been fully studied. So there is a lot of issue with the safety. It requires stringent monitoring. We see the various immature organ systems like the central nervous system. The brain barrier is immature, the receptor sensitivity might be different. So there would be a greater CNS penetration for many drugs. And the sedative effects, CNS effects may be exaggerated. Examples are chlorpheniramine, hydroxyzine, phenytoin, and morphine. So the ataxia and nystagmus side effects might be higher. And the immune system is also immature. So there would be an altered response to many drugs and vaccines. An example, preterm babies have delayed response to live vaccines. Many drugs may not be cleared very well, like chloramphenicol. There is a higher risk of toxicity. The musculoskeletal system is also developing. Many drugs may impair the growth or development of cartilage and teeth. Examples are fluoroquinolones, which cause cartilage toxicity. Tetracyclines, they stain the growing teeth. Then the cardiovascular system, so there is an immature autonomic regulation. So many drugs like opioids or magnesium sulfate, the risk of apnea, bradycardia, hypertension, that is much higher. Also, with morphine, well, adults have many cardiovascular effects, side effects. Infants would have more respiratory depression kind of side effects with several drugs. So the immature organ systems mean that the same drug dose, it can cause an exaggerated effect or it can cause unexpected side effects when compared to adults. Now we come to the drug formulation, the challenges regarding that. There is a need for age-appropriate formulations. Older children might be able to take tablets or capsules. Younger kids would need liquids or suspension. Infants might need drops. The dosing, as we have seen, is either by the age, also it varies with the weight or the body surface area. Drugs with narrow therapeutic index and wider side effect profile might need therapeutic drug monitoring. A lot of drugs which are useful in the pediatric age group, we lack data regarding their safety and efficacy. So a lot of the uses may be off-label. We need to follow guidelines when we prescribe in neonatal or pediatric age. Coming to the ethical issues, neonates and children, they are a vulnerable group. So for each drug, we balance the risk with the benefit for prescribing. And many a time the parents are explained the benefit, the side effect, and for many drugs, consent might be taken because the balancing of the risk and side effect is very subtle, and a lot of the times, a lot of the balancing act required in our ICUs and in our OPDs, they require a lot of consideration, and in most cases we need to follow the guidelines. So the best practice recommendations are to use evidence or guidelines wherever it is available. Always individualize the dosing. Consider the gestational age, the chronological age, the weight, and the renal or hepatic status. Wherever feasible, especially with drugs which have narrow therapeutic windows, monitor the drug levels and efficacy and toxicity. Monitor for the toxicity. Interpersonal collaboration is required between the pharmacist, the neonatologist, and pediatrician. The caregivers and staff are always educated regarding the administration, the side effects, and the efficacy. And drug administration safety protocols and checklists need to be followed strictly. So in summary, we have understood that neonates and children differ significantly from adults with respect to their drug disposition. There are differences which affect the absorption, distribution, metabolism, excretion, and response to drugs. That is why we need careful dosing, different formulations, stringent monitoring, and ethical research when it comes to drugs for the neonates and pediatric age group. So with this, we come to the end of our first session. I hope the session has been enriching to you, and the coming sessions will give you more knowledge and more learning experiences. Thank you, everybody.
Thank you, Dr. Juliet, for this excellent session. Your talk has laid a strong foundation for the FCPI Pediatrics and Neonatology Forum, and on behalf of the FCPI, I sincerely thank you for sharing your expertise and for familiarizing us with the basic concepts of pediatric medications. I also thank all the participants for joining and making this inaugural session a success. This marks the beginning of our journey in pediatrics and neonatology, and we are looking forward to continued participation in the upcoming sessions too. Thank you all.